what I want to do is I want to talk about esophageal varices briefly before we get into kind of the rest of it. I think it's going to help you understand a little bit about this case and how it was handled and how badly it was handled. Not so much, you know, once the ER kind of took over, basically the second, set of ER physicians took over. It was really how this patient presented during the night shift, the previous shift, everything that happened. That's really where the issue was. Everything that the staff does later, I agreed with. Parts of it could have been done a little bit different in terms of getting GI on board. But I want to talk about esophageal varices really before this happens, and then overall you're going to realize how horrible this case was handled. So in an article published by the American College of Emergency Physicians, so this is published on ACEP now, it states acute variceal hemorrhage is a serious cause of mortality in the emergency department and can be difficult to treat. In general, upper gastrointestinal hemorrhage accounts for 102 hospitalizations per 100,000 people every single year. The esophageal varices represent approximately 14% of these cases. So again, not a lot, but we see it every now and then. Furthermore, esophageal varices are the most common cause of persistent and severe, that's the key thing there, most common cause of persistent and severe upper GI bleeding, accounting for approximately 33% of these events. Among patients with cirrhosis, 70% of upper GI bleeding episodes are caused by esophageal varices. Gastroesophageal varices exist in nearly 50% of patients with cirrhosis at the initial time of the diagnosis. Now, the article goes on to state for initial bleeding episodes from esophageal varices, 6-week mortality stands at 15%. This is down from, the article mentions a 40%. There's a few studies out there, but overall it was a relatively high percent down to 15%, but still 15% mortality is still pretty significant. And this was down from 40% 25 years ago. This high mortality rate distinguishes variceal hemorrhage from other causes of upper GI bleeding, which often resolve spontaneously and have mortality rates below 3%. This could be, ulcers and gastritis and things like that. Obviously, there's a multitude of others. But given the lethality of this disease, it is more vital than ever for emergency physicians to understand the current therapy for gastroesophageal varices and deliver that life-saving treatment. And so we're going to be talking about it throughout this episode, is how to treat this appropriately, what to do in these situations. Patients can come in feeling, relatively okay after after vomiting up blood. They feel relatively okay. Vitals are relatively fine. And then the ruptured esophageal varices happen. And without intervention, it's nearly a death sentence. So that's how, important this is. It's important for the provider to recognize the potential. A lot of times in the ER, you have patients that seem fine, and the next minute, they're not. So it's almost like you have to plan, you have to prepare yourself for the potential. You have someone that comes in, let's say as a 16, 17-year-old that took 100 tablets of Norvasc, and they present to you, let's give it 90 minutes afterwards. There's going to be some vital sign changes. There's going to be some issues going on. But what's going to happen as that progresses over the next 10, 15, 30 minutes, an hour, 2 hours is going to be the most critical time. Sometimes you see patients that literally they ingest a bunch of stuff and you see them at 30 minutes after. You see someone that just vomited blood, right? They just vomited blood and they present to you. So you almost have to keep in the back of your mind, you may be stable now, but you most likely won't be. And if you can kind of keep that in your mind, that's how you really can adequately treat these patients. You can get aggressive with the treatment. You know who to call, what to do, meds to start. You do all these things ahead of time. That's how important this is. Now, in terms of the pathophysiology itself, I want to keep this just bare basic. This all results from portal hypertension caused most often by cirrhosis. Now, there are a multitude of causes of cirrhosis. Alcohol is one, NASH is another, so non-alcoholic steatohepatitis, but there are a multitude of causes. I literally just listed just 2. So what you have is increased portal pressure and large blood vessels at several anatomic locations, including the distal esophagus and proximal stomach. As that pressure builds up, vessels can bleed. That can lead to those ruptured esophageal varices, gastric varices, and the list goes on.
ICU boarder, 48-year-old cirrhotic, here for hematemesis.
Intubated overnight, and after 1 unit, PRBCs and FFP was supposedly stable.
Not anymore, weak carotid.
All right, so this is that point when we start to take kind of a deep dive into some of the backstory behind this. I'm going to explain this in detail because, again, I want you to realize how bad this case was handled from the beginning. So we hear ICU boarder. For those that aren't medical and like, I don't know what an ICU boarder is, I am going to explain that. Well, we're 11 hours into this shift. What this means is that this 48-year-old checked into the ER via either EMS or they came in through the front door just vomiting blood and they got brought back. All right, literally vomiting blood. So he would have been seen by either the ER attending physician or the ER resident on the night shift. Now, in episode 1, Dr. Robbie gets sign out from the night shift doc. Not to say there wasn't a resident on during the night shift. There typically is, especially at a teaching hospital like this. But let's say the volume wasn't as, it wasn't as bad, maybe it slowed down for a little bit. The ER attending sent the resident home. I don't know. We didn't see a resident. We don't know what happened there. Realistically, there would still be a resident on. We're not going to let him leave, early in a busy ER like this, right? He came into a busy ER to begin with. So he would have been seen by an ER doc just like everybody else. Labs would have been done, depending on the story, maybe imaging. We really don't know anything but, cirrhosis and vomiting blood. So however long that took to get the patient admitted, all right. Now, there are no ICU beds available. That patient was admitted to ICU. We're going to talk about that later. But the patient was admitted to ICU. There's no beds available, so that patient basically becomes a hold in the ER. Well, basically, we babysit them until a bed becomes available, and that patient then goes to the ICU. This can happen with a medical patient, progressive unit, ICU. It doesn't matter. There's no bed available. They're in the ER until one becomes available. You are admitted to the ICU attending physician in this case. All right, you were underneath the ER attending physician. You place a bed request and an admit order. The ICU attending physician takes over that case. I assume he's got residents. It's a teaching hospital, so you're going to have residents on this case. They're going to start putting orders in. They're going to see the patient. They're going to start, doing all these things. They're going to come down and see that patient. Now, since they're an ICU hold, the ICU team is going to manage this patient. The ER provider does not continue putting meds and labs in. We're done. It is no longer their patient. Now, in terms of the nursing situation in cases like this, I'm not going to talk about that because a lot of the times it's the ER nurse managing this patient. They're already, backed up, understaffed. Nurses are managing their own patients, and then all of a sudden they have an ICU hold. Sometimes you get lucky and you have one of the ICU nurses come down. A lot of times, believe it or not, it's the ER nurses that are managing that patient in the ER, which I do not agree with. I think once it's an ICU patient, it should be the ICU team entirely managing that patient. But that's my input with that. I'm not going to talk about that in this lecture, but it's an ICU hold. It should be the ICU team managing that patient entirely. So let's say the patient goes into arrest. You lose a pulse. The patient's ICU hold, admitted to ICU attending. They go into arrest. The ER team is going to respond immediately, right? We're going to hear the little, sometimes they hit the code blue button or depend on the situation, but we're going to respond with immediate, literally immediate intervention, start doing CPR, meds, all that kind of stuff. The ICU attending or the ICU team is notified and they come down. A lot of times what happens is they resume care of that patient because it's their patient. A lot of times realize you have a patient that codes. One, it's bad. You get a hold patient that codes. It looks horrible. But you have a patient that's coding, you're doing CPR, and they were a hold, and you get a situation like that. That attending doc that's down in the ER may not even know that patient any of the history because they're a hold. It's not typically a sign-out case. Now, in the patient in this TV series, we don't get much on the history other than the patient likely came in during the night shift, they were admitted, they were in the ER for a number of hours, and they were intubated. All right, so for starters, does the ER attending or ICU manage that patient in the ER? The ICU team does, just like what we just mentioned. The ER team no longer manages that patient. If this patient was bleeding in the night, requiring blood, it would be the ICU team that would get notified and paged. All right, it would be the ICU team that intubated this patient, not the ER attending. The next part of this, if you are intubating a GI bleed, all right, that means it's because you're trying to protect the airway. They have so much blood. The reason you're intubating is to protect the airway, all right? That means they had a lot of blood there. They were bleeding so much, potentially elevated INR. In this case, here they get blood, so they would have got packed RBCs, they would have got FFP, so fresh frozen plasma, and then the patient was reportedly stable. So up to this point, they would have had vomiting blood, stopped, they were ultimately admitted to the ICU hold, they must have started bleeding again, right? They get packed RBCs, FFP, they got all this blood product and they were intubated and then stable again. So already now we have the second red flag that's just, firing off. And so this patient started bleeding again. and they're moved into the higher acuity room. So vomiting blood in a cirrhotic patient is esophageal varices until proven otherwise. You got to hear that mortality rate earlier. This is a serious potential GI bleed and near-death sentence once the varices have ruptured. Up to this point, we hear no mention that GI was ever consulted by the ER, that GI even saw this patient, and it appears the ICU team was actually never made aware of this decompensation. Otherwise, we would see the ICU team in the ER. Oh, I know why. They're too busy, just like the rest of the consults that we always hear, throughout the Pitt. The consult was busy. No, he's in the ER. Oh, he's busy. That's why we don't see the ICU team, guaranteed. So in this case, did the ER doc last shift, so the doc that was on before Dr. Robbie, did he even call GI? This is a patient that when you call GI about vomiting blood in a cirrhotic patient, they're going to get boarded for an EGD. They're going to go in and do an upper scope. Now, is that going to be done now? Is that going to be done next day? Obviously, it depends on the situation and what's going on. Is the patient stable, not stable, bleeding stop, that kind of thing. But they're going to be seen by GI. They're going to get boarded for an EGD. So let's say in this case that GI saw the patient when the patient was seen initially by the first ER attending. The patient would have been boarded for an EGD later that day, likely because they were stable. That's totally fine. Or, depending if it was in the evening, make them NPO midnight. We're going to do an EGD first thing in the morning. Let's go ahead and start all these drips that we're going to talk about that weren't started in this case. But I'm going to go ahead and scope them in the morning. And if he bleeds at all during the night, give me a call. We're going to scope him emergently. All right, that's a typical situation. Other times, you get a GI doc that's on, they'll be like, oh, I'll scope him right now. All right, I've had both of these situations. So it really depends on the GI doc. It really depends on the situation of the patient. All right, so if they got intubated in the night, that is because they started bleeding a second time. We hear they got blood. Red flags. Come on, guys. That patient needed an EGD right now, emergently. We're not waiting till the morning at that point. If GI chose not to scope that patient on, when he came in vomiting blood because he was stable, that's fine. You started bleeding during the night shift. The second time to potentially intervene on this patient was ignored. Any GI physician that is consulted on a patient with cirrhosis coming in vomiting blood is going to see this patient. Any GI physician that did not get called originally, all right, they're going to get called now on that patient because they're intubated and they're getting blood. They're going to go see that patient. I think now you can start seeing the issue with this case. Now with this current TV case, this is the third time the patient is bleeding, all right? This is not the first, this is not the second. They had the initial vomiting blood on arrival to the ER, it stopped. They were vomiting blood during the night shift, they were intubated, blood product, and then it stopped, and then they're still in ICU hold. This is bleeding the third time. So up to this point, we don't know, besides blood product, what meds the patient was on or is on currently. With the mortality rate and how dangerous this bleed is, it's pretty standard to be on octreotide, protonics, and empiric antibiotics. Otherwise, this is truly a delay in care and a delay in the proper management of this patient. Now that we've explained the diagnosis and how serious this is and the dynamics of this case, I want you to watch this play out, and I hope you kind of have a little bit more of an understanding of what's going on.
Shivati, I need you on section.
Why is she bleeding all of a sudden?
Most likely bleeding is from the esophageal varices. With cirrhosis, you get enlarged veins under pressure at the entry of the stomach, varicose veins, and they can burst.
What does that mean?
The cirrhosis from the hepatitis B caused a vein to burst where the esophagus meets the stomach, and that's where the blood is coming from.
So unless this family member was not present earlier, or the patient had no family, the family member would already know this, and the ER doctor would have explained this to them last night, unless the suspected diagnosis of esophageal varices was never discussed because the ER doc missed it, missed the diagnosis, never consulted GI at all. That's why GI didn't come down. They were never consulted. They had no clue about this case at all because they were never consulted. I have so many questions here on this poor and mismanaged case. This is disappointing.
BP's only 82 over 46.
Hey, Mom, you're gonna be okay.
Rapid infuser, massive transfusion protocol, Piotride bolus and drip, 80 pantoprazole and ceftriaxone. Perla, get Robbie in here.
So we hear blood pressure is 82 over 46. So the patient is in hemorrhagic shock, and this is likely secondary to the ruptured esophageal varices. The resident states to activate the massive transfusion protocol, which basically means the patient is going to get a lot of blood product, which is what the patient needs, besides all the stuff they needed earlier already. They have been transfused in the night. They got blood product, and they reportedly stabilized after blood product, intubated, stabilized, etc. Now they're bleeding again. Massive transfusion protocol is being done now. So now they're getting even more blood product. All red flags are still going off. I really hope you're starting to see the issues with this case. Now she states octreotide bolus and drip, pantoprazole or Protonix, and Rocephin or ceftriaxone. Now, if she stated this now, it means the patient never got those medications to start with, and this is bad. Those drips would have already been running normally. The patient would have already received the octreotide bolus, would be on the drip, would have received the first dose of antibiotics already. And in terms of the Protonix itself, either on the drip or more commonly, evidence-based medicine suggests 40 milligrams Protonix BID over the drip itself. Different thing. I'm not going to talk about that. The point is here, they had the meds right, so I really want to focus on the meds right. It's just at the wrong time. All right, this is comparable to like a septic patient. You are septic, you are sick, and there's a numerous hour delay in antibiotics, and they die. All right, there is that delay in care. There's a STEMI, so a heart attack, cath lab patient, where the EKG was not recognized on arrival as a heart attack until it's too late and the patient had a cardiac arrest. And then you look at the EKG and you're like, that was a heart attack. A pulmonary embolism, for example, is diagnosed and the provider forgets to start heparin. You see where I'm going with this. They had the meds right. They were just given at the wrong time. So again, it's not on the current ER team because they recognized what was going on. It would have been on the previous ER team that failed to recognize all of this. These meds should already be started. This is just horrible. So to recap, this can all mean a few things. The night shift ER doc that saw this patient originally diagnosed the patient and admitted the patient, but did not manage this patient properly, did not start the correct medications, actually didn't start anything. But it also means that since this was an ICU hold, the ICU team would have seen this patient. They also missed the diagnosis because they saw the patient. Why didn't they add those medications, right? Sometimes if the ER, starts certain things, they're admitted to ICU, ICU changes certain things or adds other things. So why didn't the ICU add those medications? They didn't either. This was another missed attempt, not just the ER, but also the ICU. It also means that GI was likely never consulted either. I can promise you this. If you call any GI physician in the country about vomiting blood in a cirrhotic patient, they're getting blood product, right? They're currently being transfused and you call GI and say, hey, I have this patient, they're actively getting blood product and has history of cirrhosis and they're currently vomiting blood, intubated overnight. They're gonna say, I need you to start this and this and this and this. That's what's going to be done. If you call GI on this case, they're going to have you start those medications. The entire hospital is risking a lawsuit in this case. Horribly mismanaged patient. So you may be saying, Dr. Taylor, what needed done in this situation? Patient comes in, even if stable, history of cirrhosis, vomiting blood, even if only one episode prior to coming in. This can be what's called a sentinel bleed. This is the small bleed that happens, sometimes a little bit bigger, but this is the bleed that happens before the massive bleed, all right? This is your time to catch it. This is your time to really evaluate what's going on. Be like, dude, I need to get intervention. I need to intervene at this time. I need to get GI on board. We're gonna be doing a lot of things, right? The sentinel bleed is basically your chance to intervene here before that potential death sentence of the massive GI bleed. So let's say you have this patient, vitals are stable, hemoglobin's stable, you give a call to GI, you explain the case, what's going on, episode of bleeding prior to arrival, currently stopped, patient stable, all right? You call GI with that. They're gonna tell you, go ahead and start Protonix, Rocephin, and octreotide, all right? You start then all those medications. A lot of times you can start those before calling GI, and I routinely will do that. It's kind of two birds with one stone. I'm gonna order these medications, and then at the same time, I'm calling GI. So it's not uncommon. The point is that's what's gonna happen, all right? Some docs would do an EGD at that time, like, yeah, I'll scope them right now. Or, if it's later in the day, the patient's stable. Again, what we talked about earlier, they're gonna, go ahead and scope them in the morning, all right? But what's gonna happen is that, let's say that patient stays, stable, they're on Protonix, they're on Rocephin, they're on octreotide, they're seen by GI, they're gonna be boarded for a scope first thing in the morning. We're typically going to put them in the progressive care unit or in the ICU because they have a high risk of decompensation. All right, this would have been the perfect scenario. All right, but this would be too easy. This is a dramatic television show, right? This is medically dramatic. We want to dramatize everything, so we're just going to mismanage this case, and we're going to watch all this stuff play out. Let's just mismanage everything and make it really unrealistic for TV to the point that it's exciting and it's dramatic, and let's advertise it as realistic. Makes no sense. Come on, guys. Now, on that same patient we just mentioned, all right, let's say in this situation, stable. They're now a hold, all right? So this is a normal situation playing out. You've already spoke with GI, they're on the meds, they're boarded for a scope in the morning, all right? They've already been seen by GI. And they start bleeding again during the night shift, all right? They had to receive blood product. Again, ICU is being notified, GI is being notified, the patient's being intubated. ICU would have actually have called GI, and they would have been scoped emergently right there, all right? They would have went to endoscopy, or potentially bedside, depends on the ER and your abilities. Wouldn't have been done obviously in the hallway. So again, I'm not going to critique all that. That's a different situation. The point is they wouldn't have been scoped in the morning. That's kind of the caveat with this. It depends. Patient stable, not stable. A lot of times when you admit these patients, if the scope isn't until morning, the GI doc's going to be like, well, give me a call if anything changes. Hemoglobin starts to drop, patient symptoms change, and that's an emergent EGD. So in the TB case, because none of this happened, we now have a patient 11 plus hours with a delay of care, potential delay for diagnosis, but a delay in care with a mortality rate rising by the minute without the proper medications. Wow, is this a poorly mismanaged and handled case.
Hemorrhagic shock from varices, failed medical therapy.
She states hemorrhagic shock from varices after failed medical therapy. No, to fail medical therapy means that you were given actual medications and then failed. Like if you have an infection, you're on antibiotics, you're on your antibiotics, you get worse, you go to the ER, they admit you on IV antibiotics, you failed outpatient management. Like you failed medical therapy. She didn't fail anything here because she didn't actually get the medications. She didn't get any medications up to this point, including the meds that are standard of care in a variceal hemorrhage. Anyway, these next few references come from the Division of Gastroenterology and Hepatology and the Department of Medicine at Lankenau Medical Center in Wynwood, Pennsylvania, and of course the Division of Gastroenterology and Hepatology at Thomas Jefferson University in Philadelphia. So they cite an article published in the Clinical Liver Disease Journal, in quotes, they stated variceal bleeding is a devastating complication of portal hypertension. EGD is widely accepted as the gold standard method to detect esophageal varices. In another article, according to the Mayo Clinic, the article states, bleeding esophageal varices are life-threatening and immediate treatment is essential. Treatments used to stop bleeding and reverse the effects of blood loss include using elastic bands to tie off the bleeding veins, medicine to slow the blood flow into the portal vein. That was the medication that we already talked about, and diverting blood away from the portal vein. So they kind of summarize some of the treatment for that. So again, in this case, the patient didn't fail medical therapy. It's 11 plus hours way too late. The patient never failed medical therapy. The physicians failed her. Every physician that saw this patient failed this patient. She went that length of time without proper treatment. Standard of care was not met in this patient, and this was a potential lawsuit. Again, both these cases were horribly handled up to this point. I don't even know how many times I've said the word horrible. It's bad. Like, it's bad. It's to the point I just didn't want to finish this. Now, with the procedure that follows, though, this was great. It kind of sort of made up for it because I get to talk about that procedure and super excited about it because I'm going to, kind of put an example on the screen for you. And so we're going to go through that together. So with the procedure that follows, that was awesome, but I think that's why this TV medical drama did everything with this case so that we can see the procedure that follows. But I would argue we wouldn't be at this point if this case would have been handled appropriately and to the standard of care.
Suction stopped working.
Because your canister is full.
I'm on it.
Oh my God.
Someone please take her out.
Oh,
Thank you very much. By the way, that is not how you raise patient satisfaction scores. Okay, Dr. McKay, do you want to explain to Javadi here all about the Minnesota?
Ah, yes, the Minnesota box. As with a lot of procedures on the Pitt, I'm going to place a video on the screen. We're going to talk about it. This is courtesy of MRAP, discussing placement of a Minnesota tube for bleeding varices. Now, since a lot of the procedures, if not all the procedures on the Pitt actually utilize MRAP, why not watch the actual video and let's go through this together before the actual procedure takes place? And I think it's going to kind of help you understand. You're going to be able to see the basically the similarities and be like, dude, this is so accurate. This is so realistic in terms of this procedure itself. Your standard kit will have the tube itself, 2 3-way stopcocks, 4 dual lure lock caps, Christmas tree tubing connector adapter, clamp with tape around the tube so you don't cut your tube, manometer, 50cc syringe, marking pen, lubricating jelly, and a traction device. Kerlix is used in the case of this particular video. You're going to need a liter bag of saline as what they use here and a bucket of water. Obviously, a few modifications can be made in terms of the traction device itself, but that's what they're using in this particular video. Now, there are 2 balloons, one for the esophagus and one for the stomach. You also have suction holes for the stomach and suction holes for the esophagus. There are 6 ports total, but we're only going to talk about the useful ones. So let's go through what she's holding here in this particular part of the video. There's one port for suctioning the stomach and another port that looks very similar that is meant for suctioning the esophagus. Not every patient will need both inflated, which is really the point of this suctioning, which is to determine, do we have blood in the esophagus, not the stomach, vice versa, or both. There is a port for inflating the esophageal balloon. One of the ports has a manometry port, and the other is for inflating the stomach balloon. If you remember, we have 2 3-way stopcocks. One of them gets placed into the stomach balloon, and the other into the esophagus balloon. Next, you're going to check the balloons for leaks. She puts them in a bucket of water here and checks for any air leaks via bubbles. Great technique. Realize in an emergent situation like this, you don't have time to do that. Some patients, this bleeding looks like an exorcism. We don't have time to check for leaks. We just do the procedure. This is considered a potentially life-saving procedure. In the case of this video, though, we can take it step by step. Once you've checked for leaks, go ahead and remove that air. Next, you lubricate the tubes and the balloon. This goes in very similar to an OG tube or an oral gastric tube. Remember, the patient is already intubated in this case, so one hole is gone. So all you have is one hole left to get this tube in. Sort of makes it easier. It's still difficult, but it sort of makes it easier. Yes, the blood is all over the place, but at least you get some help here since the patient is already intubated. You want the stomach balloon entirely in the stomach. You inject 50 cc's of air into the stomach balloon and then get an x-ray to confirm if it's below the diaphragm. You can see how this would be an issue in someone that is actively spewing blood, and this is like really, really bad. But you're gonna get an x-ray to confirm it's below the diaphragm and in the stomach. This is why you need to make sure you're down far enough. The key thing here is that you're only injecting 50 cc's. You only need a little, just in case. Remember, this is to confirm. You do not want to be in the wrong spot, fully inflated, and then you get the x-ray. That would not be good. Once confirmed, you can fully inflate the balloon. The Minnesota box stomach balloon holds 500 cc's of air. That's a lot. In this video, you can clearly see all of the pushes of air that she is doing here. Remember, we are trying to tamponade the bleeding. We're not doing just some small balloon here. We're trying to compress the varices, to compress the walls. This takes a lot of air. Think of the size of the stomach itself. You have bleeding varices, this inflated balloon pushes against it and the bleeding stops. This is temporary only. This still needs fixed. When done, cap it off and take the syringe off. The important next thing is traction. This is where the Kerlix comes into play here. In the video, she makes a knot and hangs it on an IV pole. You don't need a lot of pressure for this. Next, she hooks up suction to the gastric port and suctions out the stomach. Once this is all done, you're going to clamp the port utilizing the Kelly clamp. Remove the suction from the gastric port. Next, find the esophagus port, attach suction here. We're looking for persistent bleeding, and if so, then inflate the esophageal balloon. Some patients may have esophageal varices that are bleeding. Some, they have gastric varices. Some have both. Now, she uses the manometer in this video. I'm not going to explain that for the sake of time. Now that you've seen this procedure, you're going to see a little bit later of just how exactly spot on the Pitt made this.
So, best way to stop the bleeding is direct pressure. First balloon goes in the stomach as an anchor. Second runs the length of the esophagus for direct pressure on the varices.
First, we want to inflate the balloon underwater like a bicycle inner tube to check for any air leaks.
Javadi, subcock in the port.
Use a 50 cc syringe.
Suction's good and running.
I got it. Here you go, hon. Langdon called the main line.
You gotta be kidding me.
Princess answered, told me you were busy, just wanted you to know.
Okay, noted. Thank you.
You see anything?
I don't have to.
Just have to push the tongue out of the way in order to pass the tube.
Okay, here we go.
Heart rate's 124, BP still only 84/42.
Bleeding is still brisk.
Get another unit on that infuser, please. How far did you go?
50 centimeters. Dr. Robbie?
Did you say 50 centimeters? Yes, that's plenty. Inflate the gastric balloon. Start with 50, and then we'll check the placement of the stomach with an X-ray.
You can already tell how spot on the procedure is compared to the MRAP video we just watched. My critique is not, again, with the procedure itself. That's spot on. It's very realistic. I love that. My issue with this entire case is the potential malpractice and misdiagnosis involved in this case. That was hard to watch. This case had negligence. It did not meet standard of care. Are the writers trying to portray, this as a potential lawsuit case? Sure. Then I guess you could say this is realistic if that was the intention. But I doubt it. Or do they just drop the ball on how this patient should be managed and, assumed it was correct, which in that case, it would be an epic fail and 100% not realistic.
Why is Dana still here?
She refuses to leave. That's perfect placement.
Whoop, whoop. The portable X-ray. I mentioned this on previous critiques, mainly at the beginning of needing portable X-rays more often. What you're going to notice here is a beautiful X-ray showing the inflation of that gastric balloon within the stomach. And remember, compare that to the one we just watched in the step-by-step on the model earlier. Love this. Overall, the procedure in general, the procedures in the Pitt are generally spot on. It's really just everything else that ends up being the issue. Sure, there's a few critiques here and there on one of the episodes. I think it was either episode 1 or 2, whatever one had the pericardiocentesis. I think it was episode 1, where I even questioned the angle that they were putting that needle in. It wasn't on the same angle. It wasn't angled towards that left shoulder. So even the angle was off. But overall, in general, the procedures are pretty spot on. It's just everything else.
She wants to finish your shift.
Of course she does. Never met a charge nurse who wasn't a stubborn bitch. Okay. In an adorable way, of course.
I honestly don't know what we'd do without her.
The mouth's filling up again. It's like a fountain.
Dr. Robbie, we need you in trauma too.
Yeah, okay. I'll be right there. She's still bleeding higher up in the esophagus.
Natalie.
Got this?
We got it.
Thanks.
Perla? Yeah. She's not bleeding in her stomach. We have to inflate the second balloon up in the esophagus to do the job.
Dr. Robbie,
Yes,
we need
fuck,
you.
I'm coming. Fucking Langdon.
This port is in the esophagus. A ton of blood. Mystery solved.
So very good here. The patient is still bleeding after tamponade was attempted in the stomach. The gastric balloon is inflated. So in this situation, next up is the esophagus, very similar to the video. What's just messed up overall is like the whole entire time, nobody is called GI. GI is not even aware of this patient. Multiple times that they could have intervened and GI has no idea what's going on. Somebody page GI, please, or have them page, like speak with GI here. Like this is just crazy. This horribly mismanaged case. This is a type of case that's going to be reviewed big time. This would not just be a peer review, so every physician that handled this case is going to get reviewed. In residency, like in a residency program, this is actually what we call an M&M case. This is a morbidity and mortality case. This is discussing that case in particular. If you watched ER, again, I don't remember which season, but there was an episode where one of the docs was discussing a case literally in front of an auditorium of people. That's what an M&M case is like. That's a morbidity and mortality case. Some of those things you're getting drilled. So this is the type of case that would be. On top of that, this is a potential lawsuit case. That's how bad this case was handled. It's horrible, horrible.
Pump up the esophageal balloon to 30 millimeters mercury.
That's an insufflator and a manometer.
Yep, just like a fancy bike pump. We are at 30 and shut the stopcock.
Barely any blood coming from the esophageal port. The balloon stopped the bleeding. Tomorrow, GI can cauterize the veins.
All right, so we hear her say tomorrow GI can cauterize the wound. Now this implies, okay, did she speak with GI? Or is she just assuming GI can cauterize tomorrow? You want to delay this another day. Now, granted, the patient just got tamponade, but you want to delay this any longer. GI at least needs to see that patient now. Don't state, to everybody else, GI can cauterize the wound. tomorrow. Let GI make that call. Somebody page them, discuss the case. They're going to come down and see that patient. You want to delay this another day? You're all getting sued. This is ridiculous. After having explained earlier all the issues involved in this case, GI still has not seen this patient. Now what you have is a mismanaged originally, potentially undiagnosed, admitted without drips, no meds, no GI consult, bled overnight, intubated, transfused blood, remained in basically an ICU hold in the ER. ICU never saw that patient, started bleeding again, got a Minnesota tube as the patient was in hemorrhagic shock, got transfused again, and still GI has not seen this patient. Ridiculous.
That was awesome. I learned from the best. So, what happens next?
Once she's stabilized, the GI specialist can do an endoscopy to try to cauterize the bleeders, or they might put in a shunt to take pressure off the bleeding veins. And she'll go to the top of a transplant list for a new liver.
The top of the list? It's that serious?
It is, yeah. But once she gets her new liver, she should be able to return to normal life.
Okay. I guess I always knew that this day would come, but somewhere in the back of my mind, I hoped that maybe it wouldn't.
It's a lot for someone your age to handle. Is there anybody we can call, or?
Oh, no, it's just us. It's been that way for a long time.
I'm sorry, that's really hard.
Yeah, it's good she has you. Yeah, I'm the same age that she was when she first got Hep B. I know it's hard to believe when you look at her, but she was a wild child and an intravenous drug user. But she got clean the day that she found out she was pregnant with me, and she has been ever since.
She sounds like a good mom.
She's the best. Are you close with your mom?
Sure, yeah. Like proximity-wise? It's just not the first word that comes to mind. It's complicated.
Usually is, right?
Yeah.
I mean, my mom hasn't been perfect. I mean, sometimes I really hated her, but I always loved her. And I knew that she loved me.
Yeah, it's a long road ahead, but it's a marathon, not a sprint. All you can do is take it day by day. We have a great social worker here, Chiara Faro, if you want to talk to her.
Maybe a little bit later. I think I just want to be with my mom right now.
Yeah, of course.
Yep.
If you're a GI physician watching this episode, I'd love for you to comment on this case and how the Pitt managed it. Not consulting GI a day ago, not starting any drips, patient getting intubated, blood products, still no drips, now getting both stomach and esophageal tamponade with still no consult to GI. Any GI doc, it doesn't matter if you're an attending, if you're a GI fellow, please comment on this. I'd love to hear your take on it.